Thank you to Carlton for inviting me, and thank you, Linda, for a talk that could not have set up my talk better. I feel like I can skip the first half of it now, and we can all get outside again. So what I'm going to talk about today is the definition of pain, which I hope isn't going to be as academic and dry as it sounds. I hope I can make the argument throughout this talk that it matters both clinically and in the public policy domain. So let's kind of get right into it. What is pain? Okay, so U.S. Justice Potter Stewart had this to say, I shall not today attempt to further define it, but I know it when I see it. Okay, now, that was a little bit of a fib because Potter Stewart was actually talking about pornography, but I think the same thing pretty much applies to pain, is that every one of us recognizes pain. It's the easiest thing in the world to know that you are in pain. Pain demands your immediate attention. There's no, I wonder if that's pain. You know immediately. But once we try to define it, it gets a lot more difficult, okay? And as I said, I think how we define it and how we conceptualize pain makes a big difference to how we, how we make public policy decisions, how we make clinical decisions, and I think, as the last talk really set up, how we treat people who are in pain. So let's start with this. If we know pain when we see it, what does it look like? So this is a patient that we had, an individual we had in the lab who we have put a little thermode on his arm, and we're going to administer a thermal stimulus. Oh, sorry. It's a very small little thing I got to press here.
Ow! Wow!
We are actually nice people, okay? There's a couple of things I'd like to point out there. Okay, so clearly there's a sensory aspect to this. He's got a, 30 millimeter by 30 millimeter thermode on his arm. He could, if you asked him, he could tell you where that is, et cetera, et cetera. So there's a sensory quality to this. But I think what you see here, he's not saying, oh, that feels warm, it's about here and here on my arm. What you're mostly seeing here is a strong aversion response, okay? He's having a really, a quite noticeable, unpleasant emotional response, okay? And those two aspects of pain are clearly outlined in this, which has come to become the canonical definition of pain from the International Association for the Study of Pain, okay? It's gone on without me. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage, okay? And so, I've highlighted sensory and emotional. We can't have one without the other. Pain is by definition emotional. Okay, so let's get on. So what does it do? Why is it sensory and emotional? What is the function? And to illustrate this, let's hear from somebody who was born without the ability to feel pain. Okay, so this is an individual born without the ability to feel pain due to a loss of function mutation in the sensory neuron sodium channel NAV 1.7. And what that is basically what we call a nociceptor. Some people informally call them pain receptors, but basically there are channels in the periphery that respond only to noxious stimulation. We call those nociceptors. These are deficient in this individual, and he's going to describe to you an injury.
The last time I broke my foot, it was actually out in the woods and it was nighttime, so it's pretty much like walking around with your eyes closed.
Mm-hmm.
And when I broke my foot, I didn't instantly know that I did it because I was stepping over a stump, and when I stepped over, there was another log on the opposite side of it that my foot had got wedged into, and it twisted it, and I fell over and cracked it. And I didn't know that happened until after I tried to get back up. And when I got back up, I went to go put my foot down, and I could hear the cracking of bone, but then also I had like this, like a rush feeling, like a um, kind of like just like blood, like it felt like blood was going through my leg, kind of is what.
Okay, so we see, this gives us a pretty good indication of what pain is good for, okay? So this individual and individuals like him are susceptible to the kinds of injuries that you or I would be able to avoid fairly routinely, okay? And I think another noteworthy thing here is that the way he describes it is so matter of fact. I feel like he probably felt less emotion in describing it than you felt in watching it, right? I mean, it's kind of gruesome to listen to, and for him, it's just kind of matter of fact, okay? And because of this, so, immediately when you tell somebody that this person is born without the ability to feel pain, a lot of people will say, oh, that sounds awesome. It really is not awesome. It really is terrible. I mean, this individual has made it to, he's 35 or 40. A lot of these individuals don't make it to that stage because they succumb to injuries very early in life that could easily have been avoided, okay? A very interesting thing about talking to this individual was that over his life experience, he had learned behavioral ways of avoiding injury that for you or I would be immediate, okay? So he would say, when we had him in the scanner and we were testing, giving him some thermal stimuli, and he said to us at one point, maybe we should stop. It feels kind of like when I used to burn myself with a lighter. And what I, took from that is probably when he was a teenager or something, it was a party trick he would do, hey, watch this. And, he learned, okay, that actually resulted in a terrible injury, and therefore, anything that feels like that, I probably shouldn't do again, okay? So he had learned many ways of avoiding injury but they are immediate to the rest of us. So, as soon as if I had stepped over that set of logs, I probably immediately would have felt something weird and tried to pull away, okay? And, even in a more mundane sense, as I stand here, okay, if I stand too long on my right leg, I probably will switch over eventually to my left leg because it starts to get a little sore, okay? A lot of individuals born without the ability to feel pain will get a lot of damage to their joints because they will never do that. They will just keep standing on their, and that's standing on the limb or, having pressure on limbs that, the rest of us would just instinctively and reflexively avoid. Okay, so this is certainly not anything that you want. So all that to say, when we ask the question, what is pain good for, we could think of it like an alarm that alerts us to the state of our bodies. Okay, and then it becomes quite clear why we would want a sensory and emotional component, because we have the sensory component so that we are alerted to the place on our body that may be in danger, okay? And the emotional one not only tells us that, okay, this is something serious, something I need to pay attention to, but it also readies us for action, okay? So it becomes very clear when we think of it that way why, it's important adaptively that we have both a sensory and emotional component of pain. The other thing I like about this analogy comparing pain to an alarm is that it can help us sort of understand some strange situations. We can say, anyone who has a fire alarm knows that, okay, if your alarm is out of batteries, it will not go off when you're actually having a fire. And that's very much like this individual who can't feel pain. He's got an ineffective fire alarm, so to speak. The case we see much more often is in the case, in cases of chronic pain where it may not be warning us about any immediate danger, and it's much like, those of you who've had a fire alarm that goes off, whenever you make toast or whatever can appreciate how annoying that can be, but, this is, as our previous speaker has kind of made clear, many, many more times more troublesome, to have an alarm system that is going off constantly, okay? Now, historically, where we have struggled maybe as a field quite often is in conceptualizing this relationship between sensory and emotional components of pain. We often don't know what to do when we don't see what the sensory component is, when we can't observe some ready pathology, okay, and we see emotionality, we see people having an emotional response. We have had a tendency as psychologists and as a medical community, I will say, to think that pain is somehow psychological in origin. And this really has its roots in sort of psychodynamic explanations. We see here, an example of somebody demonstrating a quote-unquote hysterical patient. And I really enjoyed the question earlier about, how the maybe latent, or maybe I shouldn't say latent, maybe I should say blatant sexism involved here, because, we talk about hysterical pain, we often act as if women, who have strong emotional responses to pain somehow must be inventing their pain. It must be hysterical. So there's this sort of, again, I was going to say undercurrent of sexism. Maybe it's just flat out straight sexism, rather than an undercurrent or a latent thing. And we've done, I'm not going to talk about it today, but we've done some research in our lab suggesting that it's actually men who tend to report pain inaccurately when they come in the clinic, not women. Women are accurately reflecting the pain that they have, and men are, bound by some man code to pretend that they're not in pain. And that does not help either set, especially when clinicians act as if it's the men who are reporting accurately and the women who are exaggerating the pain. So unfortunately, in terms of understanding that link between sensory and emotional components of pain, we as psychologists have done really well. We've adapted things like CBT and ACT to help patients who are experiencing pain, living with pain. But I'm not here today to talk about psychology's greatest hits. I'm going to talk about some of our greatest misses, unfortunately. So this does not reflect, I do think psychologists have a great role to play and are playing it, but we've also made a few mistakes. So typically when we cannot find peripheral cause for the pain or some injury or pathology that clearly explains why somebody is in pain, we've tended to, say pain is psychogenic, okay? And that comes from a very influential 1959 article by George Engel called Psychogenic Pain and the Pain-Prone Patient. And this is very typical of this kind of psychodynamic approach to mysterious pain, okay? And what Engel said was that, pain really can fulfill a psychological need, and that a lot of these patients are having pain because they're guilty, and it's not readily apparent that they're guilty, and so they have to express it as pain. And he presumed, he states in this article that weak nociceptive pain, or what he would call real pain, can be distinguished from psychogenic pain by its sensory features and by the complexity of the description. And even though, we've moved past, believing this kind of explanation, but it really does live on. It really has stuck around, and this idea that pain that we don't understand and that appears as complex must somehow be psychological in origin, okay? And oh, sorry, that's just a repeat. I want to get across what, it was said very nicely by the psychologist Large in 1996. There are no psychological tests that reliably distinguish between, quote, psychogenic and somatogenic pain. And anyone looking for such a test has misunderstood the nature of pain and the needs of patients with pain, okay? So this idea that because pain appears complex, that it somehow must be psychological in origin is nonsense, okay? And, we have a bit of a track record in our diagnostics of sort of making mistakes with this. This goes back to, DSM-3 had, basically every version of DSM until the most recent one has some version of psychogenic pain, in which, we say, okay, pain without a clear medical cause must be psychological and is a psychological disorder. The DSM-3, for example, in 1980, which was around for, a decade and a half, in some form, said had a diagnosis of psychogenic pain disorder, which was pain inconsistent with the distribution of nociceptors or without detectable organic pathology, okay? And the implication being, therefore, that it was psychological in origin. Now, we have more or less moved past that. DSM-5 now has something called somatic symptom disorder. And this is, I'll just go through kind of what this looks like. They have finally, and thankfully, gotten rid of the last traces of causal language. So they're no longer making a claim that the pain is caused by, some psychological factor. And there's no more language about, medically unexplained pain, okay? And so that's good. We've made some inroads. So in order to get this diagnosis, you need one or more somatic symptoms that are distressing or result in significant disruption of daily life. And then the next category is excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns as manifested by at least one of the following. So we have disproportionate thoughts about the seriousness of one's symptoms, persistently high levels of anxiety about health or symptoms, excessive time and energy devoted to these symptoms or health concerns. And then we have a time qualifier, so it's, has to be around typically for 6 months or so. Okay, so, we've made some inroads because we have got rid of that causal language, and, that's good. But, it's not that this way of thinking about pain, which this dangerous way, I think, of thinking about pain has entirely gone away. So to illustrate this, I'm going to go to, this was a case study that, DSM, when they put out a new diagnostic and statistical manual, they accompany it with a book of case studies. And so this is one of the ones taken from the case study, and I think it's quite instructive. So they introduce us to a patient named Michelle Adams, who is 51 years old. She was formerly a hairdresser until pain, made her unable to work. She's been experiencing debilitating chronic pain for the past 13 months, and her primary care physician has requested a psychiatric evaluation. Okay, so just in terms of going through the criteria, so, we need somatic symptoms that are present for at least 6 months and are causing distress and disability. Okay, so we see, I won't read this whole thing, but I'll, bring out some highlights. She'd been suffering from unbearable back pain for the last 13 months. She had been unable to return to work since her accident on account of the pain. She often found herself up until 5 a.m. and pain woke her up several times before she finally got out of bed in the afternoon. She had stopped bathing daily and gotten slack about cleaning her apartment. She just did not feel up to socializing on account of the pain. Okay, so this is clearly taking a big impact on her life, so that, she's meeting the criteria in terms of functional disability. Okay, and then, she also has a number of thoughts and, issues with dealing with, the emotional response to these symptoms. So she reports that she's so depressed it's ridiculous, and she feels hopeless of any possibility of living up without pain. Okay, so far, it seems like we're in pretty good stead. Like this seems a very reasonable way to approach this. Okay? What I want to draw your attention to here is some of these qualifiers where we say this, emotional response is excessive or disproportionate. Okay? So what this diagnosis really hinges on is whether we consider her cognitive and emotional response disproportionate or excessive. We reviewed in the previous slides, she's had unbearable pain for 13 months. She's confined to a wheelchair. She's unable to work. She's lost her social life. She's sleeping poorly. And furthermore, her primary care doctor doesn't know what to do with her, okay? Now, I would put to you, is it really an excessive or disproportionate response that she feels depressed about that she feels hopeless about that. I mean, that doesn't seem all that disproportionate to me. It doesn't seem excessive in the slightest, given that the impact that it's had on her life. And unfortunately, I think that this notion of what is excessive or disproportionate emotional response to pain is determined more by the clinician's comfort level with that emotional response than by, it being actually disproportionate to the patient's circumstances. As, from working in a pain clinic as a psychologist, I know a lot of the consults we get are because the clinicians are uncomfortable with patients who have strong emotions about surrounding their pain. Okay? So we see here, these doctors keep telling me I'm good to go back to work, she said, with visible anger, but they don't know what I'm going through. Her voice broke. They don't believe me. They think I'm lying. Okay, so let's evaluate her claim that she isn't being listened to or taken seriously. I want to just draw your attention to some other things that are reported in this case study. Okay, so they say, the psychiatrist was struck both by her appearance and her manner. Here was a woman with shaggy silver hair and dark sunglasses, seated in a wheelchair, who offered a limp handshake and a plaintive sigh. She asked the psychiatrist if he would mind pushing her wheelchair into his office. She was tired from a long commute. Nobody on the street, she says to the psychiatrist, nobody on the street offered to help me out. Can you believe that? She described a hot temper as a family trait. She revealed several arrests for theft in her 20s. Now, I want to just have a little thought experiment here. Let's imagine that we actually did know the origin of her pain. Let's say that she had a benign tumor on her spine, and her doctors had told her, listen, we don't want to operate because there's a significant chance of paralysis, but the sort of downside is you'll have to live with pain. So if we knew that, I wonder to what degree any of these variables would be relevant. Would we be saying it's excessive that she is worn out from a long commute? Is it unreasonable that she is surprised that somebody isn't helping her in a wheelchair? Is her shaggy silver hair relevant? Is her arrests for theft in her 20s relevant in any way? Is her hot temper relevant? Would it be relevant? And I would like to assert that, the reason that we are noting these is because we, in the absence of a clear peripheral cause, we are presuming that this is some kind of loony bird that, is coming in here with her kooky silver hair and her history of theft and her hot temper and making something up, okay? That this pain is somehow psychological in origin. Okay, and I think you could talk to almost any pain patient and they would convey a story like this. Usually it's just in the form of people telling them, oh, the pain's all in your head. Now, what does that mean, I wonder? When somebody is told the pain is all in your head, are you saying that, there is a nice way to think about that. Yes, it could be, your brain, something in your brain is creating pain. But I think more often what we're saying is, it's not really real. You don't really have pain, okay? And I think that this is really endemic still, even though we no longer call pain psychogenic, but this is, I think any pain patient will tell you that they experience this kind of disbelief and this kind of discrediting frequently. And it's largely based on these antiquated notions of pain for psychological origin. And patients who present with emotional responses to their pain have worse healthcare, really. So this is from an article, from a review article by Tate and Chibnall and Kulkarni. In the absence of clear pathology, patients appearing, quote unquote, histrionic in their pain report, i.e. Presenting with emotions that the clinician is uncomfortable with, they receive fewer tests and less follow-up. They're more likely to be denied appropriate treatments, and they're more likely to have their pain attributed to psychological causes, okay? And one of the great figures in pain science, Pat Wall, had this to say. If a diligent search has been made in the periphery and no cause is found, we have seen that clinicians act as though there was only one alternative. They blame faulty thinking, which for many classically thinking doctors is the same as saying that there is no cause and even no disease. They ignore a century's work on disorders of the spinal cord and brainstem and target the mind. And, in other places, Wall says, what we mean by the mind is some mystical miasma. It's, off in the ether somewhere, okay? It's not, there is no actual physical mechanism. And this is, one of my biggest complaints about this. I'm not denying that psychology and, your psychological state, your emotional state has an impact on your pain. Obviously it does, and nor am I denying that we as psychologists have a role to play in that, much as we play, if somebody goes through a divorce, if somebody loses their house, we can help, right? We say, you are going through something very difficult, we have some coping strategies. So we as psychologists have a huge role to play. And we also know that if somebody is very depressed, their suffering will be worse, and it has a way of facilitating pain. So it's not to say that there is no link, but one of the things that concerns me about this, in addition to the sort of demeaning and disbelieving feeling it gives to pain patients, is that as soon as we say, oh, this is all in your head, or this is psychological in origin, we give up the search for an actual mechanism because we think we've solved it. Now, that is not a mechanism, okay, to say that this is of some kind of psychological origin. I think what we can do is say, psychology is substantially, affecting your pain, and, look for mechanisms, actual biological mechanisms, testable, falsifiable mechanisms by which somebody is having pain. But all too often, when we declare that somebody's pain is psychological in origin, we just stop looking. And we say, okay, well, they don't belong in my pain clinic. They should go to, go have their, go to a depression clinic or something like that. So just a few clinical conclusions here. First of all, pain's emotional component is definitional and central to its function. So it's, it's not that we have pain and then we have an emotional response to pain. Pain that is not emotional isn't pain. Okay, by definition, pain is unpleasant, and again, the IASP definition sort of cements this. Another conclusion I'd make is that by definition, the reality of pain does not depend on observable somatic pathology. Okay, the fact that we don't know where it comes from and don't have a readily observable source does not mean it isn't pain. And I think one of the probably the most important part of this definition is the last part. So we say an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage, okay? And what this means is if I come into the clinic and I say, my leg is in pain, it feels like it's on fire, the clinician should not say, well, it's obviously not on fire, get out of here, okay? The fact that I say my leg is in pain means I'm in pain, okay? Now, there are random cases where people malinger, as there is with any disorder, okay? But that is very, very rare. So, what I would strongly advocate is that when somebody says they're in pain, we believe them, okay? That should always be the default. We believe them until until circumstances prove beyond a doubt that we should not. But I think it should always be our default to believe patients. And then the final conclusion I'd make in terms of clinical stuff, how we conceptualize the relationship between sensory and emotional components of pain can become a critical piece of the clinical and social context in which individuals live with pain. Okay, so if you are not believed as a patient with pain, that makes your pain journey much more difficult. Much more suffering is involved, okay? And I, just to illustrate this, another of my interests is Lyme disease, because we have a similar dynamic going on that, many people with chronic Lyme disease are not believed. And I have a patient or a patient partner in one of my studies who also has cancer. And she says, you know, actually the Lyme disease is worse than cancer. Even though the cancer will probably in the end claim my life, the Lyme disease is worse because with cancer, everybody believes me. I go into the clinic, my doctor can't be more helpful. With Lyme, people are always telling me that it is some cuckoo disease, and you know, my doctors don't know or frankly don't care, they're tired of me, et cetera, et cetera. Now that is a huge piece of why people suffer with pain, okay? So what I would put forward is that pain is also very much a social phenomena, okay? How it lives in the interactions between you and your clinician, between you and your family, between you and your friends. And so in defining pain, some people have tried to work that more, you know, that piece more into the definition. So here is an alternative definition proposed by Williams and Craig. Pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components, okay? So this really emphasizes the clinical, the complexity of pain, and it emphasizes how, you know, pain has a cognitive component, it affects how we think, it affects our social life. And again, I think as you heard in the last talk, and as you know, if you talk to anybody living with pain, it's much more complex than my arm hurts, okay, or my leg hurts. People will tell you it changes their entire identity. I used to be somebody who helped other people, and now I am somebody who needs help. I used to be a runner. You know, people would define themselves as a jogger. Suddenly they're not a jogger anymore. They're somebody who has trouble getting off the couch. So it doesn't just affect their leg or their arm. It affects how they go out into the world. It affects how they see themselves and who they see themselves as. And you know, I really liked in your talk, Linda, that, you know, that journey was there. It's like suddenly I didn't know who I was. I don't, you know, and I've had to rebuild my identity through that. So, you know, what most people living with pain have to go through is way beyond just the feeling that they have in their leg or their lower back or whatever. It's a very complex experience. So there is one issue with you know, there has been a redefinition, so this was the old definition, I'll show you how they've changed it, and it's to this last phrase, with actual or potential tissue damage or described in terms of such damage. And the issue that came up around this definition was in the description, is people would say, do I need to describe it in order for it to be real? You know, does this depend on you know, me being able to verbalize what I feel? And you know, that's hard enough often for people who just don't have the words, but when they went looking for another definition, they also wanted a definition that would allow for non-human animals, okay? So, you know, does this mean only, you know, verbal humans feel pain? Or, you know, what about infants? Do they not feel pain? What about, you know, older individuals with cognitive, you know, with dementia or whatever? You know, the fact that they can't describe it, does that mean it's not pain? So maybe we need to think about this a little differently. So this has been rewritten as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Okay? Now, in the section that follows, I'm going to talk about some public policy ramifications for how we think about pain. And this idea of pain, you know, resembling, or, you know, we can judge pain based on whether it looks like pain becomes very important, okay? Because when an individual isn't able to verbalize pain, or, you know, a non-human animal, we are stuck trying to judge how they, you know, whether they're in pain. And one of the ways we do that is with their behavior. Now, I teach an honors seminar on pain, and one of the best ways to, you know, introduce the idea of, you know, or to get people thinking about what pain is to trace through, you know, this long-standing debate on whether fish feel pain. Because here, you know, it really gets us down to, okay, what are the essential components of pain? What is necessary? And, you know, there is a very vigorous debate in the scientific literature on this that has ramifications for instance, the fishing industry and how we ethically treat fish. Okay, so one of the pillars on which we make that judgment is their behavior. So here, Braithwaite and Bulcott, who are arguing that fish do feel pain, are pointing first to behavior. So they say, the fact that changes in the normal behavioral repertoire of the fish studied occurred in the administration of noxious events, or following the administration of noxious event, does allow us to infer that the fish attended to this noxious stimulus in a way that was not just reflexive. Okay? So they're really saying, essentially going back to what we said earlier, I know pain when I see it. I can see that this fish has responded to this noxious stimulus with avoidance behaviors, and therefore I can infer that it is in pain. But that's not really enough, because any organism can pretty much avoid a noxious stimulus. Fruit flies, will avoid a noxious stimulus, and many of us would not say that, we would not say that a fruit fly feels pain or anything that we would, say resembles pain. And the reason for that is that we don't think that they possess the what we see to be the relevant neurobiological substrates of pain. Okay, so the second pillar on which we often make these judgments is to ask whether the organism has the requisite neurobiology to experience pain. Okay, and so they, in doing so, Braithwaite and Bulcott point to the presence of nociceptors in fish. So they say teleosts possess specialized cutaneous pain receptors that are sensitive to damaging stimulus such as excessive heat and noxious chemicals and to mechanical pressure. And they say the presence of a nociceptive system is clearly a necessary component for the perception of pain, but alone it does not provide evidence that the fish have awareness of the stimuli we would consider to be painful. Now they go on to make arguments about why they believe fish do possess it, but what is introduced here is the idea that the nociceptor alone is not enough. You need something to process that information, okay? And so Brian Key, on the other hand, says that, okay, well, fish may have nociceptors. They don't have what we would call the brain substrates necessary to feel pain. So they say the alternative view that fish instead respond to noxious stimuli reflexively and with a limited behavioral repertoire is defended, so he believes that this is just reflexive response within the context of our current understanding of the neuroanatomy and neurophysiology of mental states. While mammals and birds possess the prerequisite neural architecture for phenomenal consciousness, it is concluded that fish lack these essential characteristics and hence do not feel pain. So he's saying the fish may have a nociceptor so that it can respond reflexively to a noxious stimulus, but it does not have what it takes in the brain to feel pain, okay? So just because we might agree on the types of evidence that are required for us to infer pain doesn't mean that we make the same interpretations. Here we have two very good sets of scientists, and if you read either of these articles, you will, you would say these are compelling arguments. So typically, I often have my students break into debate groups, and each, I'll give one paper to one set and one paper to the other, and they end up, based on reading these, really believing it because they make strong arguments one way or the other, okay? So we can have the same evidence and interpret them differently. So what I would say to you is that, or maybe a way to carry this on and maybe a little bit more clearly and relevant to ourselves, is to go into another type of organism. So this debate was carried on largely on the pages of scientific journals that most of the public will never come near. But there's a very, a parallel debate that took place in a much more public forum. And many of you will remember this case. It was very, very consequential. Mississippi asked the Supreme Court to overturn Roe versus Wade in the abortion case that many of you know about. And this case was called Dobbs versus the Jackson Women's Health Organization. And basically, the state of Mississippi put in a law in 2018 saying that you could not terminate a pregnancy after 15 weeks, okay? And eventually this went to the Supreme Court and it resulted in Roe versus Wade being overturned. Some of the new evidence that was presented in that case was that fetuses prior to 24 weeks could feel pain, and therefore, it was judged that it was inhumane to terminate a pregnancy when the fetus could feel pain. And the reason I'm bringing this in is that we are, you'll see in a minute, these arguments followed largely the same track. They said, they made their judgments based on observed behaviors and then on the presence or absence of necessary biology. Okay, so this is a amicus brief prepared by Maureen Kondich, who is a neuroscientist at the University of Utah and also quite a prominent anti-abortion activist. So, she initially is pointing to behavioral evidence. 4D ultrasonography confirms that even before viability, fetuses react to painful surgical procedures by grimacing and making other facial gestures recognized by science as a universal language of conscious pain experience. Okay, so when people are in pain, or especially acute pain, they often make characteristic faces. And so we recognize this apparently as a universal sign of conscious pain experience. But in terms of the neuroscience, the argument that you're making in terms of differentiating between a 24-week termination and a 15-week termination is based on the necessity of the cortex for pain, okay? Because it's pretty much accepted that the cortex only begins to develop in a fetus or is only, beginning to form in a way that is functional by around 22, 24 weeks, okay? And so in order to make the argument that a fetus prior to that time is able to experience pain, you basically have to make the argument that pain can be experienced without a functioning cortex. Okay, and that's what she does. She says, in order to do so, she cites the work of Stuart Derbyshire, who is one of our earliest pain neuroimagers, and who about 10 or 15 years ago came out with an article asserting that no pain can be experienced without a cortex and that therefore a preterm fetus cannot experience pain because it does not have sufficient cortical substrates. Okay, and so she says, faced with mounting scientific evidence to the contrary, Derbyshire abandoned his position on the cortex's necessity just last year, and she cites a 2020 article by Derbyshire and Bachman, which we're going to go into a little here. So this article was called Reconsidering Fetal Pain, and in it, Derbyshire says, several papers have now been published suggesting that the necessity of the cortex for pain experience may have been overstated. And I can tell that the suspense is absolutely killing you all. And so I'll let you know the papers he's citing are papers that I was involved in. So I am in a unique position to comment on whether these claims are accurate or not. So the first study, he says, one study has, for example, demonstrated continued pain experience in a patient with extensive damage to cortical regions generally believed to be necessary for pain experience. Okay, so before I begin unpacking, the evidence for or against that, we need to go back just a little bit and to the, what neural areas we think are necessary and sufficient for pain experience. Okay, so before we started using neuroimaging, we had some ideas about the neural substrates of pain, and those were mostly gained from animal models, okay? But we lacked kind of in vivo data from humans, and so neuroimaging was seen as a really important tool in order for us to understand how it is that humans feel pain. And already by 2005, we had a pretty good idea, because almost any neuroimaging study you run, you get almost the same regions. And frankly, if you run a neuroimaging study of pain and you don't find these regions, you begin to doubt that you've done something right. Okay, so this is really ubiquitous in this field. So we see regions like the anterior cingulate, the thalamus, the insula, primary and secondary somatosensory cortices, et cetera, okay? And just to reinforce that, this is a sort of meta-analytic tool called Neurosynth. Here we see 311 studies of pain meta-analyzed. And again, we see these same regions. You see the anterior cingulate up kind of over the top of the corpus callosum. You see the insular cortex. You see the thalamus lit up, et cetera, et cetera. Basically, as I said, if you run a pain imaging study and you don't see a map that looks something like this, you probably have done something wrong. Okay, now this Neurosynth map is going to show up again, so just keep it sort of stored away in working memory there. Now, the question that arose, we saw it in every pain imaging study, so we began to ask, is this necessary and sufficient? And we did a study that suggested, and the study that Derbyshire was referring to when he said, you know, patients born or without these regions still feel pain, was from this study that we put out in 2016 in Brain Structure and Function. And you have already seen the patient that that this paper is written about. So this is the individual you remember from the beginning who had a very robust pain response. Very fascinating. I could do a whole talk on this individual, but what is fascinating about this individual is that at age approximately 20, because of herpetic encephalitis, which is basically the herpes virus crossing the blood-brain barrier into his brain, large portions of what we call the limbic system are lesioned, okay? So those black areas are not just kind of, I haven't turned up the brightness on my computer or this is a lousy image. Those are lesioned areas. So he has essentially no anterior cingulate cortex. His insula is almost destroyed. His thalamus is severely damaged. His amygdala is severely damaged. Okay, so all of these regions that, you know, imaging would have told us are absolutely necessary for the experience of pain are damaged, and yet we saw quite clearly that the individual experiences pain. Okay, what I would say to you though, so what this study did was make us question whether these specific regions that we see in these imaging studies are necessary. I don't think that it made the claims that Derbyshire is making on its behalf, because what you will, you know, those of you who are familiar with neuroanatomy can see that most of the cortex is still intact. So this study does not support large claims about the function of the cortex. The other thing I would say is that we collected this data when he was about 53, so it was about 30 odd years after his injury. And, you know, a lot of plasticity can occur over that time. So it's very possible that regions that for you and I may be necessary, basically that function has been taken over by other regions of the brain, okay? So we don't really know that. I mean, ideally we would have loved to test him immediately after the injury and then, you know, many years later, and that really would have told us more about that. But I would say that those claims by Derbyshire are not really supported here. So second, he says, back to Derbyshire and Bachman, a further study has demonstrated activation of areas generally thought to generate pain in subjects congenitally insensitive to pain, but receiving noxious stimuli. And you probably know where this is going. So he's referring to a paper we put out in JAMA Neurology in 2016 called The Pain Matrix in Pain-Free Individuals. And once again, I've given you a preview of this individual. So the individual who is talking to us about breaking his ankle on a wood pile was one of the ones we put in the scanner. So we had two patients who we put in the scanner. And what we did was we got a small group of individuals with normally functioning nociceptors, and we sort of gave them a stimulus that, you know, most people would find, they found painful. You know, it's called a von Freyhair, but I would compare it to being poked with a pencil, okay? So all of the individuals with working nociceptors reported it to be painful. These individuals did not. They said, you know, I feel that it's poking me, but it doesn't, you know, whatever pain is, I don't feel it. And what we see, so in red you see that Neurosynth pain matrix. So that is what we would call the kind of conventional pain matrix. And what we see is that these individuals had equivalent activation in that pain matrix to the individuals with healthy nociceptors, okay? And then when we extracted that activation, so in the plots there you see, they're the ones outlined in yellow, and individuals with working nociceptors are the ones in blue, and you can see that the level of activation is basically equivalent, okay? And what that says to us is that these regions are more reporting a salient stimulus rather than pain per se. Now, what that says, in Derbyshire's article, it sounds like this is making an argument that these regions are not necessary. What this is really saying is that this is not sufficient evidence that an individual is pain. So just because we see these areas lighting up does not mean we can conclude that those individuals are in pain. So this is not, in his article, he cites it as if it is evidence that these regions are not necessary. It is not that kind of evidence. It is, because that pain matrix was so ubiquitous, there was calls to use, pain matrix activation as medical and legal proof that pain was there. And what this is saying is that that is not, you can't do that. That's not evidence that somebody is in pain. So we were asked by the pro-choice side of the argument to clarify, in a counter amicus brief to Maureen Kondich's, and we were joined by 35 other pain scientists in this. We were asked to clarify that evidence, or whether it did or didn't say that. So I'll just read some sections from that. Dr. Kondich's amicus brief relies heavily on the article Reconsidering Fetal Pain by Stuart Derbyshire and John Bachman, which attempts to call into question the necessity of the cortex for the apprehension of pain. Three authors of the two most important studies used by Derbyshire, Dr. Salomons, Professor Ionetti, and Dr. Feinstein, signatories to this amicus brief, assert that the results of their studies are being misinterpreted by the Derbyshire article and consequently by the state's amici. Citing a study co-authored by Dr. Salomons and Professor Ionetti on patients congenitally insensitive to pain, Derbyshire suggested that the results support the claim that the cortex is unnecessary to perceive pain. The study actually shows that in the absence of activity in functioning nociceptive sensory nerve fibers, activity of the thalamus and cortex is not sufficient to generate pain. The study does not show that the cortex is unnecessary for pain to be experienced. Derbyshire also misinterprets the results of the one-patient study conducted by amici Drs. Feinstein and Salomons. Derbyshire claims that the patient's experience of pain with a partially functioning cortex somehow provides support for the idea that the cortex is not necessary for the experience of pain. The study actually concludes that the patient's experience of pain was due to damaged brain's adaptability to develop circuits around the damaged section of the cortex. The study emphasized that many other regions of the patient's cortex were intact that could potentially be mediating his pain experience. So one thing, this was really an educational experience for me being involved in this debate. It really taught me that the types of nuanced conclusions that we scientists deal in are not the domain of the courts. So what you get are very adversarial, the Kondich article made very extreme claims about what our articles were saying, and I will say the pro-choice side, which we signed on to, also tried to make some outlandish claims. They said, they initially wrote in here that our articles unequivocally showed that the cortex is necessary. Our articles didn't say anything of the sort. They said that these specific regions of the pain matrix aren't necessary or sufficient for pain experience. And what this introduces here is, what I'm trying to get across a little bit is that there is still substantial ambiguity about what the necessary regions of the cortex are, okay? Or the necessary regions of the brain for pain, okay? So it is always going to be difficult, for us to judge whether an individual is in pain based on their behavior and the presence of the sufficient and necessary neurobiology, because we don't know what that is, okay? And so I will now circle back to our definition of pain, because I think one of the main sources of that ambiguity lies in how we define pain. And I'm going to show you maybe the difference, why other than political ideology, why Dr. Kondich could draw the conclusion she did from the same data. So from their amicus brief, they use this definition of pain. In the simplest sense, pain is an aversive response to a noxious stimulus, physically harmful or destructive stimulus. Okay, and this sounds reasonable until we realize that it could apply to the response of a fruit fly. Okay, so it could represent any reflexive response that any organism could have. Okay, so this would basically attribute pain to, or could attribute pain to almost any living being. I'll also bring out this little quote. Studies show that decorticate or hydroencephalic patients are capable of conscious behaviors, including having adverse reactions to pain. Okay, so a couple of things here. First of all, she's clearly making the presumption that the cortex is not necessary for pain, because she's saying, individuals without a cortex have these conscious responses. Okay? And another noteworthy thing is kind of a subtle little language thing. She says, adverse reactions to pain. Okay, and what this does is kind of conflate pain with the stimulus. And we talked earlier about how, all too often in clinical settings we do the same. We say if there is not a clear stimulus or a clear injury or a clear somatic pathology, then it isn't pain, okay? Nociception and pain are very different, okay? So we can have nociception without pain and vice versa, okay? And that is made clear in our amicus brief. The process of nociception is only part of what is required for pain to be experienced. And so what I'm going to bring you back to is this idea that we define pain on something of a continuum, okay? From a nociceptive reflex to a complex biopsychosocial experience. So the way that our pain system is built is that these we can have nociceptive reflexes that don't even get to the brain. They're just spinally mediated, okay? So when you touch a hot stove, your hand will start withdrawing before you feel pain and before you have any conscious processing of what you've just done, okay? If you are walking around in the night and you step on a piece of Lego, so any of you who are parents have probably done this, you're walking around in the night, you step on a piece of Lego, you step off of it before you feel pain, before you yell in pain, before you think, oh, that probably was a piece of Lego. You are already making a response. So according to Kondich's, the working definition of pain, that nociceptive reflex would be a sign of pain, okay? So in terms of this, continuum, Kondich's definition would fall over here. And that's a very permissive definition of pain. It would attribute pain to almost any organism, okay? Somewhere in the middle is what we would call the ISP definition that we've already reviewed, okay, because it is a more complex experience, beyond just a simple nociceptive reflex. And then I would say the Williams and Craig definition that we introduced is much further in terms of, encapsulating the entirety of a pain experience and all of its complexities, social, cognitive, emotional, etc. Okay? And I think this is a debate the scientific community will continue to have. I think it's legit, I don't think that, I would certainly advocate for a definition of pain closer to the, complex biopsychosocial experience, but I'm not here to tell you which one should be pain. This is a debate that we can have, and I think, we may very well say that, all of these organisms do feel pain and we should treat them accordingly, okay? But here's why I think that this is critical publicly. In truth, I think the issue of pain, whether a fetus can feel pain, is irrelevant to the abortion debate. And here's why. I don't think that if I believe that it should be a mother's right to decide whether to terminate a pregnancy, I would also give that mother the right to decide whether that fetus can experience pain incidental to that experience, the same way that a mother is able to give consent for her child to undergo a painful surgery. On the other side of the spectrum, for people calling themselves pro-life, I don't think any of them would be satisfied if we said, okay, well, what if we give that baby anesthesia before we terminate it? I don't think any of them would be satisfied with that. So I think essentially the issue of pain is moot to the argument. So why is it in the argument? Well, I would suggest that the reason that this was raised is traceable to one of pain's primary functions, which is to elicit empathetic responses from others. Okay? When we hear that a fetus feels pain, we want to help that fetus. And in doing so, we project our experience of pain. We say, if that fetus is feeling anything like what I feel, then we really need to help it. And that's where this definition of pain becomes really important, because we are projecting our complex experience of pain on that fetus, perhaps using a definition way further to the left that would also attribute pain to a fruit fly or a fish, okay? And so just in summing up, I'm just gonna read, so we felt like now that once Roe versus Wade was overturned, it became apparent that abortion would be governed largely by elected officials at the state level. And this is where the court of public opinion becomes really critical, because this is the sort of emotional claim that is very persuasive to the general public. And so we felt like, okay, we really need to make it clear what the science is saying and make it clear what we should be interpreting based on this. So we wrote this editorial in Nature Neuroscience called Fetal Pain and Its Relevance to Abortion Debate, to Abortion Policy. And I'm just gonna, in sort of, because I think it nicely sums up sort of my arguments here, I'm just gonna read a couple of sections from that article. So, the state of Mississippi's case presents clear evidence that fetuses are capable of nociception. This would be sufficient evidence if we were to use a definition cited by the state at district court level. Pain is an aversive response to a noxious or physically harmful or destructive stimulus. Such responses would not be sufficient, however, using the IASP's definition. In addition to specifying that pain and nociception are different phenomena, the IASP acknowledges the complexity of human pain by stating that pain is learned through life experience and influenced by biological, psychological, and social factors. In humans with full cortical maturity, pain is not a simple sensory signal or motor imperative. It is also a complex emotion influenced not only by the unpleasantness of the perceptual experience, but also by its meaning for us and those around us. Our pain experience may include fears for our own safety or worries about whether pain will prevent us from jogging, enjoying friendships, or providing for our families. Whether we choose to call the fetus's nociceptive response pain, one thing is beyond debate. It is not the same as what fully developed human feels. So those who would compel a woman to carry a fetus to term so it won't feel pain must be clear about what they mean when they talk about pain. They can't ascribe pain to a fetus using criteria that would equally apply to a fish or a fruit fly, but then ask the public to project their own experience of pain on that same fetus. Fully developed humans have a cortex to process nociceptive input and to associate that input with adaptively relevant sensory, cognitive, emotional, and social information. Okay? Evidence supports the claim that a pre-viable fetus is capable of nociception. Any suggestion that it feels the same pain that a cortically mature human feels, however, is an emotional appeal that runs counter to what we know about the brain and how it generates complex subjective experiences. So essentially what we're saying is what you feel about pain, whatever we decide we're gonna call pain, we cannot confuse the pain that an adult human will feel with what a fetus may feel or what a fish should feel, okay? And I'm gonna leave it at that.